continue the study of Paget disease. As we said earlier, Paget disease is rather rare in India, but it's very interesting. And then we have studied the incidence, also the common radiological features involving bones from head to toe. Some unusual features and also some unusual sites where Paget is involved also we have described. Now we will come to part 2. Again, some more unusual features. The midshaft of femur, the tibia, the humerus are involved, and soft tissue involvement is sometimes common. That's because the periosteum is elevated. When the cortex is involved, the periosteum is elevated and the soft tissue swelling may be seen. That doesn't mean there is malignant transformation. Benign soft tissue involvement is also noted. Ankylosis of spine and sacroiliac joints, because the process extends to the articular margins and then involves the intervertebral or interjoint disc. That's how ankylosis occurs. Tendinous avulsions, because the fragile bone, although it looks strong like a marble, by any minor trauma, you can avulse the tendon or the ligament. And then lysis in immobilized patients. When there is a fracture and there is pain, if you immobilize the patient, that area which is involved by Paget disease gets more lysis, more destruction of the bone. Midshaft of the tibia, for example. You see, we said earlier that Paget disease of the bone generally and frequently extends to the articular end of the bone. But here, neither articular end of the bone, neither proximal nor the distal articular end of the bone is involved, only the midshaft. And there is the area of lysis, and this particular appearance often gives rise to a differential diagnosis of fibrous dysplasia. Since fibrous dysplasia is common in the midshaft of the tibia also, one has to think and try to differentiate between these two entities. Rarely an adamantinoma of the tibia, but then adamantinoma of the tibia would have satellite lesions, not a continuous lesion like this. Many of the textbooks say that fibula is almost never involved, but there is an exception to the rule. The fibula, lower end of the fibula is involved, it's bigger, brighter, and the process goes all the way to the tip of the lateral malleolus. Again, in the lateral view, you could see the bizarre trabecular pattern of the fibula. And so far we have not described the sternum is involved. Here, it is very often difficult to take a radiograph of the sternum. If you take a lateral view, you don't know what is exactly happening in the body of the sternum. So often, the most sensitive method is using a radioactive isotope like technetium-99 and using the gamma camera and taking a scan. Here, you could see the shape of the manubrium sterni nicely, sharp margins. This is Paget of the manubrium sterni. Look at the knee joint, look at the patella. It is bigger, brighter. Not only that, there was an avulsion injury. The patella is attached to the quadriceps muscle. Whenever the quadriceps is avulsed, there is a fracture. And that fracture segment also got involved in Paget disease. That's the interesting feature of this case. Pelvis. I was telling you earlier, if you immobilize, osteolysis is much more. Look at the left hip. They pinned because there was a pathological fracture, but the area of the neck completely is almost disappeared, as if there is no bone at all. That is aggressive osteolysis in an immobilized pagetoid bone. And then again notice the pathological fracture in the neck of the femur, extensive osteolysis, the small islands of new bone in the subtrochanteric area. And then protrusio acetabular, because there is enlarged head of the femur, it involves the articular margin, also the cartilage. The cartilage is universally thinned out and it protrudes from the acetabulum. This is what is called protrusio acetabuli, a complication of Pagetoid disease. And then the lumbar spinal canal, because the bodies are bigger, they go posteriorly and encroach upon the spinal cord and the membranes. That's why you see multiple indentations with a narrowed myelographic column. Lumbar canal stenosis leading to, say, cramps in the legs and other neurological symptoms. And then myelogram, complete. In fact, we had a case at Usmania General Hospital. He came with a paraplegia because the enlarged vertebra due to Paget disease of the bone encroaches upon the spinal cord and produces external pressure. The myelogram shows almost complete obstruction to the myeloid column because of the Paget disease. And complications. If it involves the cranium and facial bones, which is not uncommon, 65% of the time the cranium and facial bones are involved, the giant cell tumor transformation is common, particularly in the facial bone. Not that giant cell transformation does not occur in the rest of the body. It also occurs, but most commonly in the facial bones. This is the medial end of the clavicle. Look at the density of the middle third of the clavicle and also the articular margin, but in between the marked osteolysis, and then pathologically, when we took a biopsy, it was giant cell tumor of the bone. In this particular case, we also saw inclusion bodies by electron microscopy in the giant cells. That's very, very typical of giant cell tumor in a pagetoid bone. And then CT scan. When do you use CT scan? As I told you earlier, whenever there are neurological symptoms, you want to know whether the pagetoid process is involving the dura, it is compressing in the spinal cord. In those cases, you may need it, but generally, for fair diagnosis, you don't need a CT scan. Bone scanning, what is the mechanism? We are always stressed upon isotope bone scanning. How does it work? Chemical adsorption, vascularity. Whenever there is a modeling of the bone and then lot of turnover of the bone, they get active. The isotope that is used is generally technetium-99, and it can be used in systemic disorders whenever there are multiple bone involved. And mostly in our daily practice, we find out to know where the metastasis occurs. Not all the metastases are symptomatic. Say, for example, take carcinoma of the breast. It is stage 2. The surgeon wants to operate it, do a radical mastectomy with chemotherapy, etc. But then you have to know, before staging, whether the bones are involved. In those cases, isotope scanning is very, very important. And then what are the bone scan findings? Earlier we have described radiological and other imaging findings. Now, bone scan findings include intense uptake. Again, the intensity depends upon the activity of the process. And diffuse involvement. Anatomical landmarks, as I said, in the sternum, there is a typical transitional type of zone. So you can find out exact anatomy of the part that is involved. Expansion of bone. Deformities. And we know whether it's polyostotic or monostatic or just multiple bones are involved. Clear-cut margins, again between the normal and the abnormal. Ends of long bones you could see. And iliopectineal line, which is important for the diagnosis of Paget disease. Look at the skull. It's all hot area, we call it, whenever there is intense uptake of both the basic cranium, frontal bone, and parietal bones, including the occipital bone, they are intensely taken up by the isotope. This is Paget disease. That means active disease is going on. Similar case, but more extensive than the earlier. This is a bone scan again. Note the areas. One, the vertebral body in the junction of the thoracovertebral, lumbar vertebral junction, and the entire calvarium and the sacrum is also involved. And look at the iliopectineal line in the pelvis. Whenever that part is involved, immediately the specialist in the medical isotope scan comes to me, sir, we'll take a radiograph of the bone just to confirm that it's patched. Scapula. We have seen a picture frame appearance in the vertebral body. Here also a picture frame. Entire cortical bone of the scapula is involved, whereas the blade did not take up the isotope. Again, note the multiple vertebral bodies that are involved, including a rib. Intense uptake in the pelvic bones, lower lumbar spine, thoracolumbar junction, and the right ribs. Notice again asymmetrical involvement. Again, to emphasize that the iliopectineal area is important. If that is not involved, this could be easily metastasis or a lymphoma or some other process. Now again, intense uptake, then whenever there is a bulge at the iliopectineal line, you should think of, is there a malignant process going on? Or is it giant cell formation? Or is it osteomyelitis? Some other superimposed process must be going on. Otherwise, nicely you should draw a iliopectineal line. Of course, in this case, the isotope is in the bladder. There is superimposition. What you see in the bladder area is the bladder filled up with the isotope and then adjacent to the pagetoid bone. Again, you see the bladder and multiple vertebrae as well as the iliac bones that are involved in Paget disease. Multiple vertebrae from the thoracic, T1, T4, T6, T10, like that, multiple vertebrae step pattern that are involved. Entire sacrum, you can outline the sacral margin. Again, notice incidentally the ischial bone and the iliopectineal line. That is the clue. For example, this type of uptake in the sacrum may be due to osteogenic sarcoma, metastasis, myeloma, any other process. But that line of ischium and iliopectineal line involvement indicates maybe it is pagetoid. It proved to be pagetoid. In the lower end of the femur, right femur, you could see all the way the process is going and a sharp margin between the normal and the abnormal. Again in the knee, bilateral, more so on the right knee. Medial end of the clavicle. Look at the sharp articular end of the medial end of the clavicle and the process involving the medial end of the clavicle. Paget disease. Now, how about MRI? Everybody is raving about MRI. How is it important in Paget disease? It's not at all important, except if the marrow fat, you want to see the bone marrow, MRI is the only one. Because radioisotope scanning, you can see the cancellous bone, you can see the cortical bone, but when it comes to marrow studies, it is rather weak. So marrow fat preservation, you could see whether it is preserved or not. There is decreased signal intensity on short TR or TE phases, increased signal intensity on long TR-TE, cortical and trabecular thickening, you could see, bowing, and insufficiency fractures. We said increment fractures or insufficiency fractures you can identify. And real fractures, of course, you don't need an MRI to study the real fractures, but subtle fractures you can identify by MRI. This is a Paget of the calcaneum, increased signal in this particular phase, uniformly involving. You could see the residual trabeculae with decreased signals, and those are not orderly fashion. That indicates Paget disease. And what are the complications? Paget disease, deformities of long bones, because not only they are sclerotic, but they are soft. That's why they bend easily. Basilar impression of the cranium, indicating some involvement of the medulla oblongata or spinal cord. And protrusio stabili in the pelvis, which we have described already. Stress fractures or increment fractures on the convex side of the shaft of the either tibia, femur or the humerus. And then real true fractures also can occur with minor injuries. There is what is called a banana type of fracture. Have you ever tried to split the banana? It splits into two nice segments. That type of fracture occurs in the pagetoid bone. And then osteomyelitis, infection, locus minoris resistentiae. So infection can occur. Osteomyelitis, particularly in the mandible. When the dental surgeon removes the tooth, in a pagetoid mandible, infection and osteomyelitis occur. Malignant transformation. Any sarcoma, in fact, Jaffe has described a mesodermal type of sarcoma. Either osteosarcoma, fibrosarcoma, malignant fibrous histiocytoma, chondrosarcoma, any type of sarcoma can occur. Earlier we were describing stress fractures or increment fractures. It's the midshaft of the femur. Look at the sclerotic cortex on the medial side, the so-called Wolff's law. Whenever there is weakness of the bone, the medial side tries to strengthen. That's why there is a lot of increment of the new bone along the medial cortex. And then on the lateral cortex, multiple transverse lines indicated by some of the red arrows, they represent either stress fractures or increment fractures. Both are the same. And real fracture also may occur in the middle third of the radius. There is a fracture. The pagetoid process goes all the way to the articular margin to the wrist. Remember, I was talking about the banana fracture. This is the type of fractures that occur. They are classical to Paget disease. And then protrusio acetabular with multiple fractures of the acetabulum. Not one, two or three fractures. The diffusely involved mixed type of pagetoid process both in the pelvic bones as well as the proximal end of the femur. Wafer type of vertebrae, what is it? A compressed, markedly compressed vertebrae, almost a vertebra plana, a flat type of vertebra you can see in Paget disease. But then there is a lot of differential diagnosis. In metastasis it can occur, occasionally in primary, in Ewing's or round cells sarcoma it can occur, plasmacytoma it can occur. So one has to be very careful in differentiating Paget disease from other entities. Other complications, soft tissue masses, benign soft tissue masses, crystal depositions in the articulations, say in the knee, in the discs, etc. Degenerative changes, of course, since it involves elderly people, degenerative joint changes may not be the complication, may be just incidental to the Paget disease. Joint ankylosis, it skips the joint, so ankylosis can occur. Neoplasms, cementomas, benign cementomas in the roots of the teeth in the jaws, giant cell tumors, and metastasis may implant over the pagetoid bone. Similarly, myeloma can coexist. Osteosarcoma de novo can arise from as a complication in the Paget disease. Fibrosarcoma, malignant fibrous histiocytoma, chondrosarcoma, as I have said earlier. Soft tissue calcifications, look at the area above the greater trochanter, a strip of calcification or ossification, a mild evulsive injury, ligamentous injury or tendinous injury produces dense calcification. Not only just calcification, it is involved by the pagetoid process. It is not normal calcification. Malignant transformation, I have already told you, either osteosarcoma, chondrosarcoma, fibrosarcoma, or malignant fibrous histiocyte. These secondary type of sarcomas occur 30% of the time in femur and 13% of the time in the humerus, and at times may be multifocal, particularly in the vertebrae and pelvis, where the many number of bones are involved. About 45% of the time it may involve. Midshaft of the tibia, Paget disease of the bone, but note the oval osteolytic area with encroaching upon the cortex and some periosteal reaction due to osteosarcoma. Midshaft of the femur, bulging, pathological fracture, some callus formation. This has to be a fibrosarcoma histologically. Radiologically, you can't really tell. All you can say is that there is a malignant transformation of the existing pagetoid disease. Another case of the humerus, malignant fibrous histiocytoma. Again, only histological type of feature, but here we can say that there is a malignant transformation of the bone. Chondrosarcoma, you could identify some of the calcifications, nugget-like calcifications, typical of a chondroid lesion. Degenerative changes, already we have described, with a protrusio acetabuli type of deformity, marked chondrolysis or thinning of the cartilage in the hip joint. Multicentric osteosarcoma. Remember I was telling you in pelvis and vertebral body, osteosarcoma can occur. This need not be osteogenic. This need not be always dense. Sometimes mixed osteolytic type of osteosarcoma can occur. Mixed type of osteosarcoma can occur. Ivory dense like of osteogenic sarcoma can also occur. Lytic osteosarcoma in Paget disease, an example in the iliac bone. And sarcomatous transformation in the maxilla, in the inferior margin of the orbit, with the expansion of the bone and density. And what are the non-osseous complications? Because if the polyostotic disease, most of the marrow is involved, extramedullary hematopoiesis occurs. There may be enlarged spleen, there may be enlarged nodes. And since there is increased flow of blood to the pagetoid process, when there is polyostotic disease, congestive heart failure may occur. At times they thought there are multiple microaneurysms, but that's not proved correct. Enlarged kidneys, again due to extramedullary hematopoiesis, and also to the increased flow of blood through renal arteries. And neurological, depending upon the site. For example, if there is a vertebra involved, it may compress upon the spinal cord, so lower limbs may be involved. Or if it involves the foramen magnum, like platybasia or basilar impression, you may get cranial nerves and including the upper part of the spinal cord with all the four limbs may be involved. And then what is the differential diagnosis in monostatic Paget disease? Say you got an ivory vertebra. Who said it's classical? But that ivory vertebra should be bigger than normal. Then it is classical. And then what are the other entities? Lymphoma can produce, especially Hodgkin's or non-Hodgkin's. Metastases, either primarily from the prostate in male or breast in the female or even other gastrointestinal malignancies can produce, like carcinoids, can produce osteoblastic type of metastases. Sclerosing hemangioma, generally a vertebral hemangioma shows lucency with primary vertebral trabeculae denser, like jail bar appearance. But when these cavernous spaces are involved with sclerosis, that may also simulate a ivory vertebra. And then there is what is called sclerotic myeloma. It is rare, no doubt. 1% of the multiple myeloma cases may produce a sclerotic myeloma, and that is if it is involving the endocrine glands, skin changes, M spike, it is called POEM syndrome. P-O-E-M. P, polyneuropathy, O, organomegaly, E, endocrinopathy, M spike, S, skin changes. In those cases, you may get a sclerotic type of vertebra and may simulate Paget. Ewing sarcoma in a child, 6-year-old, actually he was blowing holy. This is a case from Usman General Hospital. And then somebody hit him in the back. He had extreme pain. The next day he came, lo and behold, proved to be Ewing sarcoma. Another Ewing's, it's not as ivory bright as the previous case, but still minor changes. You compare with the D12 with the L2, minor changes are noted in L1. It again is Ewing sarcoma. Whereas here, not only the vertebral body, the lamina, the spinous process, all are involved in the, mostly predominantly in the sclerotic process. although there are few areas of lysis. This is metastasis from carcinoma of the prostate. Generally it is diffuse, but occasionally, to begin with, only one vertebra may be involved. Fibrous dysplasia, again fibrous dysplasia is rather uncommon in the vertebral column. Not that it doesn't occur, but uncommon. But when it occurs, it may simulate. Look at the picture frame appearance of the vertebrae. But then you compare the size of the vertebrae above, vertebra below, and also note the age of the patient. All these factors rule out it's not Paget disease. Metastasis from carcinoma of the breast. L4, completely ivory dense, but it's not bigger than the one above or one below. That is a typical feature to differentiate from Paget disease. Now, lookalikes. See, often when you see the radiological picture, we don't get the entire clinical examination, laboratory findings, or even tentative diagnosis. Pain in the back, please radiograph the spine or CT spine, because plain radiographs may not show all the time the sensitive findings. So one on your left is hemangioma, one on the right is Paget. Really, if you look carefully, it is not. But for an amateur or a junior radiologist or a student, they look the same. But then the Paget disease is brighter, lot many areas of lysis, whereas in the hemangioma, something like a honeycombing you see. One on your left, proximal phalanx is involved, dense like ivory, Ewing's, age is 12 years old. The one on your right, again proximal phalanx, diffusely sclerotic, bigger, brighter, in a 52-year-old Paget disease. But then, before you finally say it's Paget disease, please do a bone scan or a skeletal survey. It may not be monostatic. Rarely a phalanx is monostatic. So look at the entire skeleton. Lookalikes again, one Paget disease on your left, 61-year-old, enlarged calcaneum, diffusely dense, extends all the way to the articular margin anteriorly and the posterior margin. Whereas one on your right, in a 16-year-old, it is Ewing's. Look at the posterior margin, it is intact, it is not involved. That's how you differentiate one from the other. Now, polyostotic Paget disease, what is the differential diagnosis? Earlier we have discussed, say, an ivory vertebrae, a monostatic disease. What is the differential diagnosis? Now, in polyostotic Paget disease also, you find metastasis, myeloma, sclerotic type of myeloma, lymphoma, hyperphosphatasia, it's a rare entity, but then there also you get diffuse dense bones, mastocytosis, fluorosis, which is very common in this part of the country. Often you have to differentiate, but in fluorosis, you find marked calcification and ossification of the ligaments, which is rather uncommon in Paget disease. And then, of course, fibrous dysplasia, the age difference is there. This is a case of mastocytosis. How can you say it's mastocytosis? Diffuse involvement, sclerosis, by kind of marble bone disease. Marble bone disease also, but then the age. And look at in the left upper quadrant, enlarged spleen. That gives the clue that there must be some hematological disorder. And with sclerosis, it is mastocytosis. And Pagets and myeloma, they coexist. One has doesn't really cause another. They just coexist because both occur in the age group of 40 and above. And then there is partial obstruction to the myelogram. Lymphoma in a young patient, diffuse involvement in a Hodgkin's or non-Hodgkin's. Fluorosis, classical of the calcification of the ischiospinous ligaments, and then the vertebrae are not really larger, although they are denser, and diffuse involvement, bilateral, symmetrical. Whereas here it is renal osteodystrophy. Renal osteodystrophy is a syndrome where you can get osteomalacia, osteoporosis, osteosclerosis, soft tissue calcifications, and secondary hyperparathyroidism. In osteosclerotic phase, you get diffuse sclerosis of all the vertebral bodies. If you look at one glance, it looks like marble bone disease, but it's not. And then to differentiate between lymphoma and Paget, again I stress in lymphoma, patchy involvement of sclerosis of the scale bones, whereas here, not only patchy involvement, but also look at the iliopectineal bone. There are lytic areas and dense areas, distinguishing that from lymphoma. Paget disease and fibrous dysplasia, marked deformity on the right side, the so-called shepherd's crook type of deformity of the femur, whereas here there is not much of deformity, but islands of sclerosis and lysis in the iliac bone. Secondary hyperparathyroidism, again, there is osteomalacia, that's why you see the ununited pseudofractures, diffuse sclerosis, uniform ground glass type of appearance, whereas in Paget we said mosaic type of appearance, the trabecular bizarre, whereas here the trabecular bone is uniformly sclerotic. Metastases, locus minoris resistentio, say whenever in this particular case the patient has Paget disease but carcinoma of the breast. Metastases have implanted here in this site. Again, another example of metastasis being implanted in the bones involved by Paget disease. And then hyperparathyroidism and Paget can coexist. How can you tell one from the other? If you look at the proximal phalanx or the middle finger, it is dense and sclerotic. The process goes all the way to either articular end. Whereas if you look at the lateral border of the middle phalanx of the index finger, there is subperiosteal resorption of bone. That is the key to say that this is hyperparathyroidism. In fact, when clinically suspected, in order to save films, somebody asks only for the hand, particularly the middle phalanx of the index finger. The lateral border, there is subperiosteal resorption of bone. Ladies and gentlemen, we have almost finished. I said almost because we cannot be thorough in a limited time about Paget disease. However, we have tried to describe the radiological findings, how to diagnose, how to differentiate from other entities, and how many bones are involved, and the various descriptions from head to toe we have described. And then I have to really express my gratitude because I have worked in all the three hospitals, Montefiore Hospital, Usmania General Hospital, Nizam Institute of Medical Sciences. In each hospital more than a decade and accumulated experience. That's how I got some expertise in Paget disease. To sum up what all we have described earlier, these are the points that you have to take home. Remember these. Paget disease is not rare in India. So unless you keep it in your mind that there is some entity called Paget disease, you can't really diagnose. And you see what your mind thinks. It may involve any part of the skeleton from head to toe. Conventional radiology is the best mode of investigation, simplest, cheapest, and best. And then radiological features and complications are universal. Whether Paget disease occurs in England or New York, Australia, or in Hyderabad, the findings are universal. Lookalikes may mislead one unless careful studies are made. You have seen examples of how an ivory vertebra may be mistaken for Pagets or metastases or lymphoma. Similarly, other lookalikes, one has to be careful, analyze all the findings, take the clinical point in view, and then come to a final diagnosis. Bone scanning is the final word in order to make out whether one is dealing with a single bone or multiple bones, whether it is monostatic or polyostatic disease. And of course, the exact etiology is still unknown, although the viral theory is the latest, but still it's not proved.